Hi guys. Okay, I can already see two people are there. All right, that feels good. So, welcome to Glance at Glaucoma. So that's Dr. Rajarathna Thangavel for you. So we're going to discuss a few things in glaucoma, very simple things. I mean, because once you know what it is, it's going to be absolutely simple for you. So I'm just going to wait for a few more people to join us, and then I'm going to take you through because I'm going to show you some pictures, and I don't want anybody to miss those pictures because when they join in late, of course you'll be missing out on the concepts, and then you will trouble me with some questions. Okay, so can we wait for a couple of minutes? Hi, good evening. Who's that? Faiz. Hey, good evening. Okay. Good evening. Who's that? Gokula Krishnan. Good evening, Aryan. Nice. Guys, please do not ask me uncomfortable questions. I think it's out in the open that I'm no longer associated with certain platforms. So please do not ask me any uncomfortable questions. Okay. And I think you should respect my decisions. Okay. So shall we start? And of course, and every time somebody, please do not mention any platform on my channel, okay? And especially I see that whenever somebody is mentioning that, it is almost someone who does not have a real name. So I really don't know who this is. Okay, you don't even have an authentic name. So you please do not ask me such questions, okay? Yeah. Day Gokula Krishna. நீ ஸ்டான்லி மெடிக்கல் காலேஜ் தான் சரிப்பா நான் சொல்கிறேன்ப்பா study in corona time. This is only glance at glaucoma pa. Okay, so we're going to talk only about glaucoma. All right, yeah, I'm doing quite well. Yeah, you can see I look decently happy, so the pain is a little less. I put a lot of Volini gel. Okay, so I'm kind of good to go. So we'll start glaucoma. Okay, already 2 minutes have lapsed. Okay, so whenever we're going to diagnose glaucoma, we should be able to அடி வாங்க போற யார் அது ஸ்ட்ரெஸ் மேம் உங்களுக்கு ஐ எம் நாட் ஹவுஸ் சர்ஜன் பா ஐ எம் அ கன்சல்டன்ட் ஸோ I studied in KMC. I did my MBBS in KMC. So that's been like more than a decade, almost 2 decades. So we are already in the second decade. Okay, so that's long time. So let me come back to my glaucoma. Okay, so whenever you define glaucoma, how do you define glaucoma? There are two things. So you should definitely have optic disc changes. Okay, you should definitely have optic disc changes, and you should have visual field defects. Okay, characteristic of glaucoma. So this is what defines glaucoma, because it is an optic neuropathy. So what is optic neuropathy? It's something to do with the optic nerve. Yes, so there is some pathology in the optic nerve because the ganglion cells are dying, and the death of the ganglion cells will reflect on the optic nerve, okay, as certain changes. All right, now for that, to identify that, you'll have to examine the optic disc, and you'll have to look at the various characteristics of the optic disc. All right, so for that we should know the normal optic disc, which I'm not going to talk about right now because I have a picture of a glaucomatous optic disc. Now, one thing that you should all know, that when you have ganglion cells coming from all over the retina, they converge onto the optic disc. Okay, so they converge onto the optic disc and leave as the optic nerve. In fact, the optic disc is the intraocular portion of the optic nerve. All right, you all know that. Now, when the ganglion cells are dying, that means the portion somewhere in the optic disc, it will reflect as some kind of defect. All right, now that's what I say. Now let's say I'm losing a portion of hair here, alopecia. Okay, so what will happen? You will have, so maybe I'm just having my hair like this. You don't know what's happening, but now if you see like this, you'll know, okay, madam is developing. Okay, I don't have an alopecia. Okay, not right here, maybe here I have a spot, but at least not here. I don't have a spot here. Okay, so suppose some ammaya sotta vendraya. So that sotta is there, no? So you'll see the sotta. Okay, you'll see the takla. Okay, you'll see the takla portion. Okay, you'll see the takla portion, no? So exactly, we are looking for the takla portion. We are seeing that sotta portion or that bald spot on the optic disc. Is that clear? Does that make sense? And is Gokula Krishna happy with the sotta? Okay, so now we're going to look at gee, what have you done to my hair? Okay, so now we're going to look at the optic disc. Okay, so okay, now you better not type because then people will not be able to see it. Okay, so now this is actually a patient who's developing a little bit of glaucomatous changes. Now it's not very clear for you here, but I will definitely show you another picture. I'll definitely show you another picture where I marked. So what I mean to say is, now this is your optic disc and you have axons, the ganglion cells coming from all over the retina. They turn behind and go. So you have this optic disc and in the center you have something called a cup, which is like a depression. Okay, so where ganglion cells are coming, the ganglion cells are all here. Okay, the axons are all, the axons, the ganglion cells are all here. So this area where the axons are present is what we call as the neuroretinal rim, and the central portion is called as the cup. Now why do I call it as neuroretinal rim? Okay, neuroretinal. So it's a nervous portion of the retina which is forming a rim. Okay, NRR. Now I really don't want PGs to come and answer here. Can you just maintain some silence for some time, guys? Don't give a complex to the others, huh? I'm being just very frank and honest. I know you know a lot, okay, but here this is mainly for the little students, okay, the bachon, okay, really the bachon, the kids. So, so we have the neuroretinal rim, NRR, and the cup. So obviously, when you have ganglion cell death, which is the etiopathogenesis or the basic underlying pathology of glaucoma, what will happen? Where will the defect be seen? The defect or the sota takla portion will be seen on the neuroretinal rim, correct? Okay, so now I'll show the same picture where I marked it for you. Okay, and there's another thing that you should know. Now when you talk about this neuroretinal rim, the neuroretinal rim is not equal in its width. Okay, it's not equal in its width. You know that the inferior rim is maximum in its width or thickness, followed by the superior, then the nasal and the temporal. So that is what we call as the ISNT rule. Okay, ISNT. So the inferior rim is the thickest or the widest, followed by the superior, then you got the nasal and you got the temporal. So that's what we call as ISNT rule. So what is ISNT rule? ISNT rule describes the normal NRR thickness. Okay, and in glaucoma, the inferiorly located ganglion cells, they happen to die first. Okay, they happen to die first. So when they die first, obviously, where will I have the takla portion? Where will I have the sota? The sota will happen, the baldness, bald spot will happen in the inferior rim, correct? So when I have inferior rim loss, so will my inferior rim be maximal in thickness? Yes or no? See, if the inferior ganglion cells are dying, definitely it's going to reflect in the inferior rim thickness. Correct? So now, will the inferior rim, no, very good. It will no longer be the thickest or the widest one. So can I, in a different way, put it as, is the ISNT rule broken? Is the ISNT rule intact or the ISNT rule broken? Very good, Shafiq. Very good, Morris. Good, Dave. Good, Jessica. So that is why we say ISNT rule is broken in case of glaucoma. So in very early stage of glaucoma, if you want to identify, simple thing, you just compare the, look at the inferior rim. If you feel that the inferior rim is thinned out, okay, or it's equal, even when it is equal to the superior rim, you kind of know the patient is developing a glaucoma. Do you understand? Okay, so now I'm going to show you the same picture, but where I've marked the boundary of the optic disc and I marked the boundary of the cup. So now you will know. Okay, so now look at it carefully. So what I marked as 1, can you see I've marked the boundary of the optic disc. Okay, and number 2, I've marked the boundary of the rim. Okay, now this is based on, how do I mark the boundary of the rim? Is not just based on the color but based on the course of the vessel. If you see, observe very closely. Okay, you can see that it's bending here. Okay, the vessel is taking a bend here because this area is like a cup, it's depressed and it's climbing up and coming out. Can you see the bend? Okay, now when I'm seeing on a slit lamp with a 90D or a 78D lens, I definitely have a stereopsis. I have a depth perception, so I know that there is a cup is the depression and the vessel is coming out. Okay, so I can actually identify the depth. All right, I can really make it out. But for you, when I'm showing a picture which is just a 2D, now how do you identify? So that you identify, you follow the course of the vessel. Okay, you follow the course of the vessel. You can see it is a little shallowing, it's climbing up, and then it's making a turn. So this is the rim. All right, so now if you see, is my inferior rim the thickest? No, this is not yet enigma. This is not yet the bayonet sign. Bayonet is the really deep bending. It's almost a 90-degree bend. That's bayonet. This is not yet bayonet. Okay, so there's a little difference. Okay, bayonet is kind of seen in advanced glaucoma, and this is not yet advanced. All right, so now when you, no issues, we are learning. Okay, so that's absolutely okay. I'm so happy, enigma, that you know what is bayonet sign and that it's associated with glaucoma. No need to say sorry, we're just learning, so it's good. So now when you go back to, now can you see, is the is broken here? Is the isn't rule intact or broken in this optic disc? Okay, because this is superior, this is inferior, this is nasal, this is temporal. Yes, very good. In fact, you can see that the inferior rim is so thinned out. Yes, can you appreciate this? So is it a normal optic disc? Is it a normal optic disc? No, it's not a normal optic disc. Okay, now we're going to describe this in a different way. Okay, now how? Now let's say I'm giving you a topic to write a short note on and you don't know anything. What do you guys write? This is this story, they ask you, I mean, I don't know, in Tamil this is something they say like that. You don't know anything about the elephant. All that you know is about the ant. Okay, but you're going to write a big story about the elephant. Or what is it that you're going to write? The elephant belongs to the animal kingdom. Okay, and the elephant is black in color like the ant. The elephant has 4 legs like the ant. I don't know whether the ant has 4 legs or 6 legs. I'm not sure. Okay, and yeah. So something like that. You'll write a big story. One point and you'll write a big story around it, revolving around it. Very good, exactly. So like that, we're going to we know only one point. Okay, but we're going to describe. Oh yeah, 6 legs. Thank you, Shafiq. See, I don't know certain things. Okay, so 6 legs. Ant has got 6 legs. So we can write a story. So unlike the ant which has 6 legs, elephant has 4 legs and it has a tail. So there's a lot of things that you can talk about it. So same thing now. We know that the isn't rule is broken. Okay, what? Because we know that the inferior ganglion cells are dying. So we're just going to develop on that and we're going to talk a lot of things. So now there is a ratio called cup disc ratio. This cup and the entire disc. Okay, so if I divide the entire disc on a vertical scale into 10 parts, okay, this entire disc, if I divide it into 10 equal parts, how much will this cup occupy? Cup occupies from here to here, right? So okay, I marked it wrong, so it's from here to here, so somewhere around, yeah, excellent. So somewhere more than 7 parts or more, right? So normal cup disc ratio is up to 0.6. Okay, up to 0.6 it's normal. Okay, so now it's 0.7, it's kind of 0.75 maybe. So CD ratio is increased. So in glaucoma, CD ratio is increased. 1 point. Okay, now I can also say that there is thinning of the neuroretinal rim. Yes, isn't there thinning of the neuroretinal rim? Yes, to start with it will be here. Then it will be the other parts also. As more and more ganglion cells die, you will have more all the rims thinning out. So you have thinning of the neuroretinal rim. And normally the normal cup is kind of horizontally oval. Okay, normal cup is kind of horizontally oval. But now when the inferior rim thins out, what has happened to the cup? Kind of becomes vertically oval. Yes, so you kind of say, okay, so we said isn't rule is broken. So we said inferior ganglion cells are dying. Then we said inferior rim is thinned out. Then we said isn't rule is broken. And then we said the cup disc ratio has increased, and we're quantifying it, saying CDR is more than 0.6 or 0.7 or more. It means the same thing, more than 0.6 or 0.7 or more. You use a different symbol for that, okay? And then we talk about what? Vertical elongation of the cup, which is a vertically oval cup. Yes. Okay, Ashdeep, that rim notching comes very, very early. Actually, in my patient, there was a rim notching, but I've kind of generalized the thing and given you, okay? So you got all this, and by the time the rim is thinning out, don't you think the cup also becomes deep? The cup also becomes deep. That's called cupping. Okay, deepening of the cup is called cupping. It becomes so deep that it becomes like a bean pot. Okay, it becomes like a bean pot. So that's called bean pot cupping. Right? So how many points have you learned? So many things you've learned. For this, all that you needed to know is the anatomy of the optic disc, yeah, and laminar dot sign, which I will talk about it on another day, because I want to explain some visual field defects also for you here. So you understand, it's such a beautiful concept. So all that you need to know is, you need to know the anatomy of the optic disc, what it is, and then you need to know the basic pathology of glaucoma, and why the ganglion cells are dying. There are so many theories, okay? So all those theories, I'm not going to talk about it here. It's all given in the book, okay? And in okay, so to say, in my awesome book, I've given all the theories, all the latest, whatever is the latest research, even that I've given there. So you can read there. We are not going into theory here. And you need to know how to examine a patient, okay? Not you, maybe because you're students, but once you're a ophthalmic resident or something, you should know how to use an instrument to examine the optic disc. All right, okay. Now what is the other criteria to call a patient glaucomatous? Visual field. Okay, so now I'm going to just show you a visual field. Okay, now this is a normal visual field. Okay, so this is a normal printout. So you get this. All right, you get this, and this is a normal visual field. And what is this? Priyanshu, I think I've explained it there better. Abhi, let me just stick to what I want to say. Can I? Yes, that's the blind spot. Okay, this is the blind spot which represents the optic disc. And very good. So now tell me, which side is this? Which field is this? Which side field is this? Yes, that's a physiological blind spot. Very good. But what I'm asking right now is, which visual field is this? Is this the right field or the left field? Right or left? I know, I love this question. Okay, it's a left. Now why it's a left? So when you are seeing it, it's on your left. See, you're looking at this. Okay, this is the circle. Oh my. Okay, so this is the circle and it's on the temporal side. So for you, which is the temporal, so if I'm looking like you, I'm looking here, this is my left field, this is my right field, this is the left temporal, that's the right temporal. So this is on the left temporal. Yes, very good. So it's the left visual field. So this is a normal visual field. Okay, and just keep this in mind. So you know that the blind spot is a little below the horizontal meridian. Okay, a little below the horizontal meridian. All right. Okay. Now, the first thing is, when you're having this inferior rim thinning, okay, or you have an inferior rim notch, what will you have? Okay, you're going to have a visual field like this. I'm showing the right field now. Okay, this is the right field. You see the blind spot is here. So this is the right visual field. This one, okay, this is the right visual field. But what can you make out? Don't you see that the blind spot has little increased? This is actually a sedal scotoma. Okay, this is actually a sedal scotoma that is developing because this is your blind spot. Okay, this is the blind spot, and this is because of the inferior ganglion cells that are dying. Okay, the inferior ganglion cells are dying, and you know that the inferior retina serves a superior field. So you get a field defect in the superior, which looks like an enlarged blind spot, but actually this is what? No, this is not paracentral scotoma, Priyanshu. Paracentral scotoma is a little different. I don't have a picture of that today. So what I wanted to show is this enlarged blind spot. So see, a normal blind spot is, the blind spot is just below the horizontal meridian. But when you see this Okay, this is actually the blind spot. This is the blind spot, and you're developing a sedal scotoma. Okay, developing a sedal scotoma, and with time, it's going to increase. Now, shall we see how it is going to increase with time? Okay, now I'm showing you a left. See, I've got different got it from different patients so that you can see what I want to show. You visualize. So this is the blind spot of this patient. So this is, we are back to left field, and can you see an arcuate scotoma developing? Can you see the arcuate scotoma? And also he is developing an inferior one also. So eventually he'll have a double arcuate scotoma. Can you see the arcuate scotoma? Beautiful. Yes. Yes. This arcuate scotoma is also called as Bierum's arcuate scotoma. Yes, Aditi, yes, the sedal scotoma, the sedal scotoma comes actually after paracentral scotoma. See, paracentral scotoma is kind of, you'll have it's based more on you look at the decibel levels, the sensitivity of the retina, and it doesn't really give you a spot. Okay, sometimes it does give a spot, but I'm not going to give you a picture of that. Okay, paracentral scotoma right now, I don't have a picture of that. I just wanted to show you the sedal scotoma, which is also described as the enlarged blind spot, and the arcuate scotoma. Yes, so this is Bierum's arcuate scotoma. All right, clear? Isn't it interesting? So as the glaucoma progresses, okay, as the glaucoma progresses, so the blind spot increases, then you got that nice, that is because of the sedal scotoma, then the arcuate scotoma developing, and as you have the other side, okay, so as the superior ganglion cells start dying, what will you have? You will have inferior field defects. So you start getting the superior field defects, and you start getting inferior field defects, and then they join together, forming the ring scotoma. So when patient has a ring scotoma, there's one ring of area that he does not see, and he can see through the central area. So that's why he has a tunnel vision. So a glaucomatous patient can have a 6/6 vision and still keep losing vision. Yes, his visual acuity may be 6/6 because through the central area is intact. Okay, so he might still have 6/6 even when the entire periphery is gone. He may not be fit to drive. Okay, legally he is not permitted to drive, but still he can have 6/6 vision. Okay, so that is exactly why we have to check PR. Okay, so in the next video I will be talking to you about how to check visual acuity and how to check PR and what is the relevance of projection of rays. Is that clear? So did you enjoy this session, all of you? Did you enjoy learning this session? That's the most important. Okay, so till the end of my life, okay, you should remember, okay, this Dr. Rajarathna came and taught us glaucoma, and man, I do remember that. Okay, so that's exactly what I want. All right, okay, and thank you so much guys for this lovely audience. I feel so good. Okay, love you guys. God bless you all. So I'll see you with more stuff, little stuff, more stuff. Okay, I'll do. Okay, we will do the questions. Okay. Hey, what is this? I can't read. This comments is just popping up. Okay, yeah, thank you so much guys. It's not more power, more prayers. Okay, more stuff. Yes, we'll do more stuff. All right, bye. God bless you all. Love you all.